Ready to go.
All right, here's our audio live, and we are back for 11 o'clock.
All right. First, I want to say, thanks to all you guys for being here, that are here voluntary, and sorry for all of you who are being compulsory to being here because it's part of your education. Thank you for being here as well, though. I understand that I am the last person you have to get through before lunch, so I'm going to take the precise amount of time that I need to make you stay as long as possible. No, I've been in these shoes. I've sat down in those seats, and I understand how hungry your bellies can get. You guys have had the privilege of listening to my brother, who was the one that was just here. And yes, we are brothers. No, we are not. Wait a second. We are twins, but we are not each other's twins. So it's a confusing thing that you don't need to go down our family lineage right now. You're here to learn about bleeding control. We both have twin sisters to solve that riddle for you. My name is Dr. Michael Phillips. I'm the younger of the two of us. I know I look older potentially, but I am younger, in fact. So today I'm coming in here to talk to you guys about bleeding control. With thinking about this lecture, I was thinking, I'm going to be working with a group of people who get to see the front end of this all the time, which is awesome, which you've heard probably from all of us, how we talk about how much we appreciate, hopefully, we've talked about how much we appreciate you guys as paramedics and being on the front end of these situations and casualty situations and dealing with this and trying to create some kind of semblance of normality from the chaos you get to pick up from the scene, scraping the poop off, scraping the twigs out of wounds and all that kind of stuff. We appreciate that. So the other thing I understand is that there's already been at least two other lectures that have been very similar topics, one being stop the bleed and the other one hemorrhage control. I'd like to inform you that they're wrong about everything they said if it contradicts what I'm saying today, just so you know. That's why they stuck me last. No, in fact, I would reference them in this actual lecture as well. So first I want to talk about was a few statistical pieces of information. So trauma is the leading cause of death in individuals between 1 and 44. No doubt you've heard this statistic or something very similar to this statistic before. And uncontrolled bleeding, it plays a significant part of that, which makes sense, right? Trauma, bleeding, those kind of go hand in hand. Up to 30% of traumatic deaths are preventable, with uncontrolled bleeding or hemorrhage being a major factor in that. So settling into the significance of this, I know it doesn't go, over you guys or anything like that to understand that this is a very significant part of the front end of managing trauma is controlling bleeding. About 40% of patients who die from traumatic injuries experience hemorrhagic shock. So that's kind of just backing. These statistics kind of following the same theme. Mass casualty incidents, nearly 50% of patients in mass casualty incidents die from bleeding. And then lastly, one of the major topics I wanted to cover today is tourniquets. Tourniquets are an effective way of stopping bleeding in over 90% of cases involving severe limb injuries when applied correctly. Now, I'm guessing most of you guys have either had the opportunities to interact with tourniquets or have been trained on tourniquets before, so I'm probably only going to add to some knowledge and hopefully not contradict any knowledge that you've already obtained. Going back a little bit on myself, just really quickly, how did I get here? Who am I? I grew up in Southwest Missouri. I'm a first-year resident at Freeman Health System's emergency medicine residency program. I found my interest in medicine actually kind of through a unique path. I started volunteering on a medical outreach ship in the South Pacific when I was 19 as a deckhand. So didn't have any medical experience. If you would have asked me to put my finger into something bleeding or pooping, I would have said no, because I didn't have an interest at that point. But through an experience over 3 years of traveling around the South Pacific Islands on this medical ship, and seeing the need that existed out there, it slowly built an interest in myself. Finally, I realized I probably should go get some kind of formal education, for which I came back to Springfield, which is my home, and went to nursing school. So not exactly an academic myself, thought, I don't want to go all the way to medical school. That's for my older brothers. They're kind of that kind of people, so I'll let them do that, right? Went to nursing school and proceeded to graduate and work at Cox South emergency room for 7 years before I realized maybe I do want to go a little bit further, hence the fact I've ended up here after completing my medical education at Arkansas College of Osteopathic Medicine. I don't know if John told you that, who was my brother who was in here earlier, the other Dr. Phillips. He also went to medical school with me. We're in the same class. It's all very quaint, the fact that we've gone through it all together and studied in studying rooms. People like to point that out. It's true. Also, this is my very legally put out there a disclaimer at the bottom here on my last point. I don't know if it's actually showing up for you guys. It's showing up for me, but essentially it just says I'm not getting paid. Not representing any of these companies. They're not saying, hey, we'll give you a little pension for representing anything you say. Sorry, realize I didn't push the button. I'm doing it my here. So this is just a scenario I wanted to talk about. This is, everybody's got a life experience. This is one of my experiences. This is not an actual picture from the thing because I did not actually ask the patient, so I'll let you know on that. I ran into this scenario when I was a nurse at Cox South. So it was an elderly gentleman who is wheelchair bound. Unfortunately, he had got run over by a full-size SUV in a parking lot and then proceeded to be dragged around the parking lot underneath the SUV for not an insignificant amount of time. It wasn't like hit him, run him down. The individual who run him down was unfortunately intoxicated, didn't know that he was under the vehicle until someone stopped them. When paramedics arrived on the scene, they found him still lodged underneath the vehicle. Had to extricate him at that time. He had a GCS of 10, so fairly responsive. And he's not like, completely dead and we're just calling it on scene. The real question comes down to, with him having now bilateral lower extremity amputations, what would you do? I'm not looking for the answer in this, but just trying to set the scene a little bit of the scenario that was real for me and kind of applying some of this knowledge. I'd also like to point out, if you guys can see closely, and I know it's a small picture, that he has bilateral tourniquets. You might notice that one seems more professional and one seems a little improvised. I'm, mostly down with the idea of improvising if necessary, but we're going to talk a little bit about kind of what you need to look for in an improvising a tourniquet. Not just anything is going to work appropriately for tourniquets, and there's specific reasons for that. So going on, I got to remember to use the clicker. So this is just basically talking about what the process of forming a clot is. This is just basic physiology. The body's natural response to plugging a hole in a vessel is forming a platelet plug that is then followed by a clot. I'm not going to go through the physiology of that. It's pretty extensive. I'm sure that you guys have at least had the opportunity in your anatomy classes prior to this to kind of go through that. But essentially, bleeding occurs through the layers of the skin. When they're disrupted, you have a blood vessel that has a break in it. Obviously, bleeding occurs. Chemicals are released into the blood system that then activate clotting factors and encourage platelets to gather at that site, forming a plug. What we're talking about, though, is not when the body is capable of stopping this bleeding. We're talking about when it's not capable. This is trauma, right? So the body has this natural mechanism that gets overwhelmed. Some of the tools we use, hemostatic gauze for one, assists in this process, but not in the sense of you have a full-on artery that's just splayed open. Is it going to do anything for that? Going over some of the basic anatomy, it's important to understand this. I know this is, like I said, I don't want to get caught up in going down through the depths of anatomy and physiology, but I do want us to get a basic reference understanding of the veins and arteries and vessels that we're talking about here, because it does make a difference when you're deciding what and how I need to control this bleeding. For example, veins and arteries, we know that the differences that we see with veins and arteries are obviously the thickness and pressure within those systems, right? An artery is going to have a thicker wall. It's going to be under greater pressure. There's really fancy formulas that can prove all this, but I'm content in understanding that that's how it works. So with an artery, it's going to require greater pressure. With the vein, it's going to require less pressure. And then down, I don't want to forget capillaries. Capillaries being that last set of vasculature at the end point. Now, it's important to remember capillaries because they are still a source of bleeding, right? Just because we're not pushing on this huge artery doesn't mean we can't lose blood through a capillary, and it's important with certain classes of bleeding as well. For example, we're talking about just the types of bleeding we're going to see. This seems pretty straightforward, right? If it's a capillary bleeding, we're going to see some oozing, easily controlled with simple pressure, right? And most likely it's going to spontaneously clot off, except in certain patient populations. I'm sure that any of you guys can think of that patient population. This is our anticoagulated patients, right? Coumadin, warfarin, Eliquis, these populations that might clot may not form. Going from there, veins, this is low pressure. It's going to clot off. We're not looking at a pulsating, which is an artery. And then lastly, the one I don't want to overlook with bleeding is the one we can't see, internal, right? Right? Because we're thinking about, if you're like me, I got all these visual things going in my head constantly. Then you're seeing This person laying on the side of the road, there's a huge pool of blood, there's this artery shooting up above the car, and this is the blood I need to control. Well, that's true, but we don't want to forget the blood that we can't see that's in the abdomen or the chest or in the head. We can't necessarily do anything about that, but we need to be conscious that it's not the blood that's just on the ground we've lost, but maybe there's blood that's being spilled out of the circulatory system in other areas of the body that we need to kind of be in the back of our mind thinking about. Mechanism of injury is a big key in understanding what type of bleeding may be going on past this. The guy cuts his arm off with a skill saw, probably not bleeding into his abdomen unless there was some other injury there with it. Guy gets in a car accident, has an amputated arm, we could still have bleeding inside in the internal cavity that could be causing trouble we want to think about. This is just what causes the bleeding. I just wanted to kind of bring up this as a provoking thought. The idea of causes of bleeding, this is the obvious one, trauma. The one that we are all here, right? Because we signed up to be on this end of medicine, not the other end that's wound care. We're on the end where we want to see this and we want to deal something with this. This is the guy that we want to take care of. But it could be surgical. It could be something that's surgical bleeding. It could be a loss of blood. It could be pharmacological or other special procedures that have caused this, or it could be genetic, right? Genetic causes of bleeding. This is not something that you're often going to run into, but I know that you guys all get like training on, I would assume you guys get trained. I don't feel like I shouldn't say no all the time, but I would assume you guys get trained on recognizing medical alert bracelets and whatnot, in the sense of we have hemophilia being one of those common causes of bleeding that's a genetic cause. So you're not going to pick up the medication list and recognize hemophilia, but you may see a bracelet that relates to that. There also could be other causes of bleeding that go down the track of infections, or DIC, which is when your body just has no more clotting factors to use to prevent bleeding from continuing. So we need to be somewhat conscious of these causes of bleeding. Moving forward from that, I wanted to talk about how to assess how much bleeding, right? I think this is important for you guys, especially because I don't get to see what you see. I'm an emergency room physician. Although I do think it's really cool to go and travel around with you guys and ride around the bus and see what you guys see, I do not get to see that on a daily basis. What I get to see is in my room. You know where my scene is? My scene is bed 40 and bed 41 at Freeman Health Center. That's my scene. Generally pretty safe, occasionally not, but the blood I see in there is what came in after what you guys dealt with. So understanding some basics of how to understand how severe the bleeding is an important concept as well for you guys. Can be coming from open wounds. The one thing that always gets me, because we just did our trauma classes for us as intern residents, talking about these compartments that you can bleed into. For example, this is the big one that I always think about is your hip or your femur. How many times are you going to transfer grandma with a broken hip? If my experience in the last 3 months of being in the emergency room, 4 months, I don't know what it is now, has taught me anything, you're going to deal with a lot of broken hips. You're going to transfer a lot of broken hips. Not all of them are going to end up in being huge bleeders, but you're going to transfer a lot of broken femurs. And those broken femurs have the potential of blood loss, especially because there's also something else that they are likely a reciprocant of as an older individual. Blood thinners, right? So they're kind of got two things going against them really fast. That doesn't mean that it's the case. However, we want to be conscious of that. So the hip can take, it says on this picture here, 1.5 liters of blood can be lost from a femur injury. The reason makes sense. Now, if you're grandma and you got these twig legs, maybe there's not as much room in there, but you can, in the compartments of your hip, there's actually a lot of open space that can expand, right? You ever wonder how those bodybuilders get those huge legs? And those huge legs can, man, that guy's as big as my waist, right? That would be amazing because I've got a fairly large waist. But to speak to how much blood can go in there, 1 to 2 liters of fluid is quite a significant amount. I'm sure if I ask a question, we would know what the idea, or have a rough idea of how many liters is average for humans. The average human's between 4.5 to 5 liters, maybe up to 6 with a larger individual. So you're talking a third of your body fluid could be lost in your leg, right? So grandma falls out of bed last night. You get there because now other family member finds her. She's had a significant amount of time to bleed. Maybe she's not having these symptoms of, showing symptoms of worsening hemorrhagic shock, but how much blood could she lost could be significant. So the severity, the critical nature of this, that timeline makes a difference because of the location. I thought this is also interesting. This one threw me. I'm going to point it out because I think it's still a decent idea, is this fist idea, right? Fist being 500 mLs. If we all held our fist up here, I kind of betting there's a diversity in sizes. And if you look at a water bottle, right, I'm not 100% positive on how much is in that, but how many mLs is in there? 500 mLs in an average water bottle, right? It's a good thing. You guys interact with this a lot because you're hanging 500 ml bags of fluid. So there's a reference in the back of your brain that kind of helps you to recognize how much 500 mLs is. But they say a fist is a close equivalent. I would say it's probably between 350 to 500 mLs, depending on the size of the individual. So if you're seeing this as a size of a blood clot or something like that, it's a reference to see how big that is. The one I kind of liked, I've always heard this, blood on the floor, right? Looking for a pool of blood on the floor. They say 30 square centimeters is blood on the floor. Now, I don't know about you guys. We're America. Sorry, I just hit the microphone, so I apologize for everybody online. Even though in medicine we use the metric system, I still haven't quite grasped what 30 square centimeters is. It's roughly the size of a dinner plate. So not a salad plate, not a dessert plate, but a dinner plate, right? So a spot the size of a dinner plate on the floor represents about 100 mLs, which is kind of weird because you think this is 500 and this is only 100. Obviously, distributing forces across the floor, it creates a smaller level. The thing I want you to take in consideration, and they thought was important to mention in some of the reference materials, this is just another slide covering the same kind of information, is that when I'm looking to estimate blood loss and I'm looking on the ground and I see this dinner plate or 10 dinner plates on the ground, what's the ground surface? Is this concrete? Is this sand? Right? Think about how porous that environment is, and is the blood going to sink down into that environment? So is this going to be an accurate measurement, or do I need to kind of think, if I see a dinner plate on sand, that's more than a dinner plate. If I see a dinner plate on concrete, I can be fairly confident that we're talking about 100 mLs of blood loss. It's actually very useful to us in the emergency room when you arrive in these situations. I'm not saying stop doing all of everything else and get out your measuring stick to make sure it's the size of a dinner plate, but having a rough estimate of blood loss helps me to understand as an ER physician how much blood and how severe is this situation. If I'm talking I've lost a liter of blood because there's 10 dinner plates of blood on the floor, then I need to already be thinking as an ER physician what kind of interventions I need to talk about. Any of you guys know what is in a unit of blood? How many mLs is in a unit of blood? About 350, actually. So think about that for a second. So that's 3 of those bags, right? You could be given those three of those bags to compensate, all right? And we need to kind of be conscious of how much blood is lost so that you guys can be better prepared to how to take care of this patient, and then how I can be better to take care of this patient. There's one thing I kind of want to jump back to think about when it comes to here before we transition into more bleeding control itself, is the concept of blood itself and its purpose on a physiological level. We're going to kind of touch this a little bit within like some of the changing thought processes of how to approach ABCs. But think in the back of your mind that if I breathe for you and I put a tube in you, but you got no blood, what am I doing? Yeah, I'm not doing anything. Now, I'm not trying to overstep and change the entirety of all the ACLS and pre-hospital trauma training or anything like that. I'm not trying to say that, but think about the fact that if there is no blood in this individual, then I can give all the oxygen I want. It's not going to do anything, right? Because the heart in itself, very simplistically, in fact, this is told to me by one of the ER doctors I started working with in the emergency room as a nurse. They said, keep it simple, Mike. The heart is just a pump, and all its job is to pump blood from the lungs to the tissues. That's all it does. So the circulatory system is just moving oxygen to the tissues and moving waste to the lungs to be breathed out, or to the kidneys or livers to be filtered out. So if we don't have blood, we don't get oxygen to move through the body. And as importantly on the other end, is we're also going to have a buildup of toxins in the tissues, which is going to end up in tissue and organ damage, and those organs are going to start to die. It's ultimately what we don't want, because we want people to lose tissue. Time is tissue. You've heard that saying. This next slide is just going over. This isn't a formal presentation. Now, Stop the Bleed is kind of where I pulled this reference from on the left-hand side, as going down through a algorithmic approach. And my point really is more so that I think I heard John, or excuse me, I'm going to keep referring to him as John, Dr. Phillips, the other Dr. Phillips. He's my brother, so it's hard for me to refer to him as Dr. Phillips. You can understand how that would be if your brother is Dr. Phillips. That's kind of weird now. and I'm sure he feels the same way about me. But
Who had better grades?
wait, oh, thank you. No?
No, who had better grades?
Oh, no, okay. Well, we're not going to talk about that. I'll let you decide after the completion of this lecture whose lecture was more academic. We'll just say that. But mine's going to be more clinical, I promise. No. With this idea, and I heard him say it was having a planned system is important. Do plan systems always play out? Like, do you get the opportunity to count on your fingers? Okay, I did this one, I did this one, I did this one. No, I've been certified in lots of different things from my background in trauma nursing, and I can tell you that in the midst of the craziest traumas, it's very scattered sometimes as to how that all falls into line. But having a framework to go back to, especially when chaos ensues, when it starts to rain on you, when there's traffic trying to distract you because it wants to run you over at 60 miles an hour, when there's a drunk person that's trying to fight you, having a process that you can go back to is important. This is not a formal process. This is just me kind of saying it's as simple as creating a process of saying on this. Scene safety. You guys should have this hammered into you. I would imagine you have this hammered into you way better than I have it hammered to you. Once again, referencing my scene as security guards, nurses, techs, other physicians. There's everybody there. So it'd be more about the patient showing up and thinking, are they safe in our scene? Because we control the environment. I'm in the ER for the most part. Yes, there's chaos. When you guys come to do your rotations, you'll get to see it, right? But for you guys being on the front end, I want to heavily emphasize that. And I want to connect with that emphasis that I'm sure all of your other instructors are. Scene safety is important. I don't want you guys to show up as a patient in my emergency room. I would need your help in my emergency room, right? I want you to be able to help the patients that are on the sidelines. You didn't sign up for this job to be hurt on the scene. You signed up on this job to help people and get paid. So I want you to be able to fulfill the latter two, not the first one. Be safe on the scene. Call for help. Well, there's a kind of interesting thing for me always when I think about from the paramedic EMS standpoint of the world, call for help. Well, who am I calling? You guys are the people I'm calling, right? Don't overlook this statement and think that I'm thinking, okay, 911. In fact, if you actually look at it, it says 911 on their thing, because this is actually designed for training civilians. The idea of stop the bleed is more for a civilian approach. If I call for 911, it's not unapplicable. You guys call for help, right? Backup. Get backup in there. Because ultimately, if you're dealing with somebody that's bleeding out, you got two hands. You may be magically able to grow a third one, which I'm sure you guys feel like you have to occasionally in the back of a bus. But call for help and reach out saying, hey, I need extra hands on this scene to take care of this patient. Identifying the source of bleeding, putting pressure on it with your hands. Those are two things I know that with Stop the Bleed, they heavily emphasize on. And that should be a big emphasis in this lecture. Now that we're going to finally get more into it, is pressure, 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 right? We are attempting to put pressure on a bleeding vessel, so we need to put pressure. The amount of pressure, where to put the pressure, that's going to vary with the type of injury and the vessels that are bleeding. However, pressure, pressure, pressure is key. This is not an ordered list, so you could put a pressure dressing on certain ones. It could be a tourniquet that you're putting on. It could be hemostatic gauze that you're putting on. The thing I want to emphasize is putting pressure on. This is just simply a little thing. I almost got rid of the slide, simply stating the same thing. You guys know. Have your idea of scene safety because that's important, right? Going through the initial assessment. This is kind of a concept I want to jump to the idea of there's two things. There's, first of all, you're going to see me use this resource that's up in the left-hand corner, I believe on you guys' screen. I'll give you the reference for it at the end. It's actually a great site. It's put together by the TCC. There's 3 C's there if I didn't say it correctly. It's a great resource. They create booklets. And in fact, once I discovered this, I was like, man, I should have just got certified and taught what they teach because it's really good. It's military for combat medics training. But I wanted to juxtapose these because I felt like it's somewhat applicable to you guys. Because you guys are on the front lines. You're closer to, a lot of times, closer to what combat medics are doing sometimes than what I'm doing in the emergency room, right? You're dealing with a crazy situation. Who knows what's going on, how you need to assess it's a little differently. ABCs is classic. Like I said, I'm not trying to remove that from the standard education of airway, breathing, circulation, and then going into our disabilities and exposure and environment. However, one thing the military medics that I've talked to have emphasized, and some of you guys probably recognize this if you have military background, is there's an emphasis going back to the front and kind of changing that C or adding a different layer on the front when it's looking for mass bleeding. Because in our time fighting, and this is not for me, I did not serve, and I'm very appreciative of those who did serve, but I had the opportunity of talking to multiple military medics and working with them in training programs. The one thing that they've emphasized to me is that in the time that we've spent in the war on terror, there's been a huge amount of information we've been able to glean from them. And making something useful out of the losses and the casualties and the injuries that were sustained out of those has been extremely helpful to us on this end. And I don't want to overlook the appreciation we have for that. But one of the things they observed was emphasizing looking for hemorrhage and mass bleeding, right? Because once again, going back to that principle, and I want to reemphasize it purposefully, going back to the principle, if I don't have blood, then I don't have air movement, even if I have an airway, or if I got breath, if I can make them breathe with their respirations. No blood, no oxygen moving through the system, dead tissue, right? Simple. No blood, no oxygen moving through the tissue, dead tissue. Okay. This is just a simple technique. Was explained to me. I remember several years ago. This is when I was becoming a trauma nurse, and my cousin was becoming a Marine medic. There was lots of conversations between him and I about like, what do you do in this particular thing? I was like, ABCs, 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 and he's like, no, you got to do check for bleeding. You got to check for bleeding. We would get not arguments, but discussions. But looking back on it now, and the more educated version of myself, and slightly humbler version of myself, I recognize that he was right in this instance. When it comes to that first line approach, you got this person laying on the ground. You can't necessarily move them, right? I don't know what's going else on them, but I do need to have ways of assessing them. So he introduced me this idea initially, and I found it in their documents as well, was the idea of doing a sweep maneuver. I will caution you on this. If they are an IV drug user or something, take cautions of what you're sweeping, but within if the scene makes it to where it's appropriate, without moving the patient, I can do simple sweeping with my hands and look at my hands, they got blood on them, to get a basic understanding. This is not going to be something that's going to take over your other understanding or other procedures you need to do, but it's a basic understanding of saying, is there blood behind this patient that I need to be thinking about or addressing? Just simply gloves on, PPE, sweeping behind them, checking for bleeding. Going over the basic steps to a wound. Now we're going to kind of start getting into stopping the actual bleeding or controlling bleeding. So with this idea, this is just saying that, emphasizing our breaking down. What type of vessel are we treating? Is it deep or is it superficial? Is it pulsating or is it not? Either way, the answer at the beginning is pressure. Apply direct pressure right away to the wound. Call for help, but applying direct pressure is the necessary. If you can't get bleeding to stop, apply dressing. Use dressing to get deeper into the wound, packing that wound to apply more pressure to the actual area. The idea of applying pressure is important because we're trying to occlude whatever arteria is bleeding. Thinking to the other lectures you've had, whether it be hemorrhage or Stop the Bleed. I don't know if all of you guys were able to attend those, but I didn't want to get off into the idea of how am I working with a massive hemorrhage and replacing fluids. I don't want to get off into the idea necessarily of definitive care for bleeding. I'm just really trying to think about, there's blood. How do I stop the blood from coming out of person, right? Simple, simple, simple. I don't want to get too down the tracks in this idea. This last bullet you'll notice is talking about, there's some references, they suggest more layers of if bleeding soaked through the materials. Remember that if you're trying to occlude the vessel, not just catch the blood. It's an important concept. Like if you're a civilian out there, you're probably thinking like, I got this thing, I'm just going to throw it over a big towel or whatever, or ABD pads or all these things. It's not necessarily wrong, but it cannot replace pressure, right? Amount of dressing does not replace pressure. This is a big concept, actually, I want to kind of emphasize here, is that the amount of blood that I'm soaking up with amount of layers and clothing and all that is not going to replace pressure. So if I've got on scene and then I'm just trying to band it through all these 4x4s and gauze and everything on here and it just keeps bleeding through, I'm not curing the problem, I'm just keeping it clean, right? I'm just keeping their floor clean. I'm just keeping the street clean because all I'm doing is catching blood. That's not actually helping. I'm not saying do not apply more layers. That's not what I'm saying. If you need to apply more layers to assist in creating pressure in the right spot, that is actually what we want to say. And that's a big concept because in the materials I've looked over, they talk about what's the failures of bleeding control. This is one of the big ones. It's an absolute big one. I do see this in the emergency room occasionally, whether it be people coming in directly or coming in from an ambulance. They've got this big, huge dressing, whether it's a blanket or it's a towel or even it's stacks of 4x4s. That is good, but if pressure has been relieved, we're not doing anything actually to stop the bleed, right? So these are some things just to kind of think about with direct pressure and considerations. Apply pressure directly around the if you have an impaled object. This is a scenario. I know we have all been hit with this one. Like certainly by now, I'd imagine all of you guys have been discussed about impaled objects. So if you guys probably already know. I don't even have to say it. Don't remove it. Right. That's the idea. You want to see a trauma surgeon yell at you, remove a impaled object, and you're going to get yelled at. I've been through that. It was not pleasant. I don't recommend it. He's still a nice guy. He was a great guy. The person that removed it was wrong. That was me. But so do not remove the object, right? So there's some very, very rare scenarios that you might remove an object. If it's like a thoracic injury in certain places that are preventing you from doing like chest compressions, that might be a place. But I want you to stop and think. If I've got a impaled object that is preventing me from doing chest compressions, what is the condition of this patient? Very poor, right? So this is not the patient this is the patient you think this is going to be a die, most likely going to die, very low likelihood of coming back from, right? We want to stabilize it, pack around it, don't remove it. Use of pressure dressings to free up your hands. This is an important idea, right? We're going to discuss this a little bit as we go on forward. Just want to emphasize it here. You got, like I said, 2 hands. I know you guys get to grow a 3rd hand in the back of an ambulance because you have to do miracles while the other guy's driving crazily through the town. And you know what the most interesting thing, I'm going to say this, just a segue, probably the most interesting thing from my time riding on the bus in July was watching how people, this is going to be like totally going to be a trigger alert to some, if you've ever had to drive an ambulance, how people can stay completely unaware of an ambulance with horn, lights, and everything directly behind them and not move over. I am astonished. As a person who's a good citizen, I always get off the road, but it is astonishing if you cannot sense that. Man, that is crazy. So 3rd arm, we're going back to 3rd arm. You're going to 3rd arm, make sure that you apply pressure dressing so you don't have to grow a 3rd arm and become somebody that's a mutant, right? So apply some kind of pressure dressing. You can also use commercial, there's elastic gauzes, commercial bandages, and blood pressure cuffs. I would love one day to see the MacGyver book that paramedics get to write, because you guys get to MacGyver stuff all the time. Well, in the ER, we kind of get to a little bit. Surgery, maybe a little bit. For most of you, you got to stay within the boundaries of what's actual practical medicine. But I get to see some stuff, and I'm like, man, that's pretty awesome. Where'd you guys pick that up? Whether this Vietnam vet that passed it along or whatever, but there's some cool MacGyver stuff that we get to see all the time come in. Emphasis, this was something I picked up from this bullet here, applying pressure trumps IV access. Our EMS director that I worked with at Cox South, he always would tell the guys, his crews, he'd say, guys, IVs are important, but getting them here is more important, right? And I'm not saying that your skills are not appreciated. That's not saying it. And you're going to get nurses, I was one of them, right, who are going to be like, oh, you didn't start an IV? What'd you do in the back of the ambulance? Nothing? No, you guys are not doing nothing. You guys are getting the patient here. You're taking care of them, making sure they're stable on the way. But in this case, do not give up your pressure for the IV, right? Keep the pressure in the sense of, if I got more blood pouring out than I can put in, makes sense to keep the blood in, right? Large bulky dressings, just kind of saying that same thought again. Going back to, this is a principle that if you guys ever get to work around some of our physicians in the ER, and I'm not going to specifically name him because the story will make sense in itself, he will tell you this simply, that all answers are wrong. Some answers are more wrong than others. It's favorite saying. This kind of plays the thought process he was. So elevating extremities is part of the steps of controlling bleeding in extremities, right? Can't really elevate a torso, so think about this as relevant to extremities. Elevating extremity is relevant. Now, it was a classic thing that's probably been done forever, but in 2010, there was this kind of reanalyzing of whether or not this was an effective way to control bleeding. So when they went through that process and reanalyzed, they realized that there was no study at that point to really show whether this is effective. So guess what happened? They're like, nah, there's no study. We're scientists. We got to get rid of this. We're going to throw out the thousands of years of humanity and say that this is not actually useful, over the fact that it didn't have a actual study performed, or they would call a qualifying study performed on it. Well, a study was done by the University of Pennsylvania in 2018 that in fact showed the opposite. So we were able to bring that thought process back in. It's not as significant, like I shouldn't say, not significant, that's not the right word. It's not a huge amount of pressure difference that you experience by elevating extremity, but if it's my blood going out on the ground and I can reduce the amount of my blood going out on the ground by a little bit, I'll take it, elevate my extremity, right? Because it's not that we are going to cure the bleed by elevating the extremity, but if we're going to help ourselves in reducing the amount of blood, elevate the extremity. It's simple. It can be very effective in helping to reduce a bleed in patients that are obviously bleeding out. Conceptually wise, this is going down to the idea of the difference between dressings. Tourniquets versus trauma dressings or pressure dressings, the kind of idea here. The thing I want to really hammer in here, tourniquets. When do you apply a tourniquet? If you're like me, you're kind of nervous about tourniquets. I've heard lots of bad things. I've heard lots of good things, but I've also heard some lots of bad things. I get a little nervous about tourniquets, but realistically, that's my nerves, right? Tourniquets, especially after this 20-year war on tear, we've actually discovered that they're actually pretty good, right? And in fact, in the end, if you're the person with the tourniquet, yeah, it's painful, but I'd rather lose my leg than lose my life, right? So there's a concept to be emphasized there. Yeah, I don't want to cause people pain. I don't want to cause somebody to lose an extremity, but I'd rather them do that than lose their life, right? So looking at tourniquets versus pressure dressings, kind of the qualifiers to think about here when it comes to applying them. I'm going to go with tourniquets first because that's the big topic and I want to emphasize that first. When are we applying a tourniquet, right? When am I applying a tourniquet? This is for uncontrolled bleeding, but the easiest one to think about is for arterial bleeding, right? And that's easy to recognize, ideally. Sometimes it's a little bit more difficult if it's down deeper. You might not see that beautiful arcing pulsation of blood that shoots across the ambulance or the trauma room, but sometimes you may. If it's arterial bleeding and it's an extremity, tourniquet, right? Apply a tourniquet if it's arterial and it's an extremity. That's an easy answer. Get it applied. Now, going to the next side, if it's not that obvious, then when are we going to apply a tourniquet? When this other system fails, right? We're going to apply a tourniquet when no longer can we occlude it with simple or pressure or a deep pressure or even hemostatic gauze, right? So then I'm going to apply a tourniquet at that point. Conceptually talking about the differences between what I'm trying to occlude, though, with a tourniquet and a pressure or trauma dressing is also important to recognize. A tourniquet, now we're going to talk about, there's two things. What am I trying to occlude? Where am I trying to occlude? This is an important concept. If it's a tourniquet, do I want to put the tourniquet directly over the wound? The answer is no, right? The answer is no. We're not going to put the tourniquet directly over the wound. That's not going to help. We want to put the tourniquet more proximally, in other words, closer to the trunk of the individual. Tourniquets, obviously, we're using these on extremities. So when I refer to the proximity close to the trunk, that's why. It's because I can go closer to the trunk. Approximately, now there's two kind of methodologies here. There's the high and tight. If you're in doubt of where to apply the tourniquet, go high and tight. You're not going to hurt anybody's feelings. Make sure you don't get anything you don't want underneath the tourniquet, if you know what I mean, especially with legs. But go high and tight. Right? If you got the opportunity and you notice that this is where the tourniquet is, then we want to achieve a distance of approximately 2 to 3 inches more proximal to the wound. So for example, I'm going to give you an example. If I've got this wound that's way up in my leg and I can't say where that blood's coming from because it's not easily visualized, it's deep laceration, I'm going to go high and tight, right? If I've got a amputation below the knee, I got a pretty good idea of where that blood's coming from. Even a deep laceration below the leg. Do I need to go all the way up to the hip? No, not realistically. I can go proximally, and even it doesn't have to be that 2 to 3. It needs to be at least 2 to 3 inches, right? I don't have to get my measuring stick. I just think about it. I need to be above that. Why 2 or 3 inches? Our vessels are kind of like bowstrings. You cut them, they're going to snap back a little bit. So what's going to happen? When now that thing that was right there at the wound where it got injured is now going to retract more proximally to the wound. So by scientific methods, like I said, the other Phillips, you're going to find that they were able to kind of see that that's an approximation of how far that vein will retract, 2 to 3 inches. So apply 2 to 3 inches above it. Now going to our pressure dressings. This is going to go back to applying to the wound, right? We want to apply this directly to the wound. We want to pack deep in the wound if it's a deep wound. We want to get that dressing all the way in there. We want to use hemostatic gauze if we need to apply dressing. We want to apply a second layer of dressing on top of it if we need to as well. Let me actually go back real quick. Let me making sure I hit all my points off of that one. Sorry, because I know I'm going to go a little bit more in depth on even that. Bleeding control is also something, say I don't have dressings, I don't have tourniquets. This is a little bit extensive, but the concept is basic, right? There are certain pinch points of our arteries and vessels that you could attempt to occlude by putting pressure yourself. Become the tourniquet with your hand, your thumb, your finger. This is just a simple kind of idea of pressure points. So identifying and using pressure points to control bleeding. To identify these are a temporary measure to effectively control bleeding until the tourniquet or pressure bandage can be applied. It involves applying pressure at appropriate pressure points to compress the artery approximately to the wound. Simple. This is not the Chinese acupuncture pressure points. These are the pressure points that are cross sections, areas in our body where arteries become more easily compressed. This is a useful thing to think about because more than once, even if, say I'm going to let down, for me, going to go let down a tourniquet occasionally, because as an ER physician, I let down tourniquets, right? You guys bring it in, I let it down, see if it's bleeding, and then I quickly tighten it back when I find out it is, right? But I can also, in certain areas, use a pressure point to kind of help reduce the amount of blood that I'm going to lose due to that letdown, right? Because I can do this a lot faster, and I can move my fingers and clamp down a lot faster, and I can retighten a tourniquet occasionally. Not always going to work, but it's a concept to understand. If you don't have a tourniquet and you don't have a dressing, don't forget about there are pressure points. Search for them. A lot of times they're simply in locations where I don't know where you check pulses, right? Those are good ones to think about. Looking over the next slide here. This is just kind of some of the thought process when to apply a tourniquet. We've already kind of talked about this. There was a concept that they talked about in the TCCC, which I don't know why they had to go 3 C's because it makes it difficult for me to say, but they talked about don't be flippant with tourniquets, like in the sense of don't just apply them willy-nilly. Like I don't want you guys to roll up in the ER and this guy's got 4 tourniquets on and he's got 3 abrasions and 1 laceration, right? Don't be flippant, but you guys have the power to make the decision to apply a tourniquet, so don't hesitate to do it because there's a lot of evidence out there that says early application of tourniquets saves lives as well, right? So I like what they say here, keep it simple. If you roll up to this person and say, oh gosh, that's a lot of blood, they initially said another word. If you say, oh gosh, that's a lot of blood, apply a tourniquet. Basically, if you approach a patient and say that, you need to be thinking, I need to put a tourniquet on, right? These are some types of tourniquets. I thought it would be cool to demonstrate lots and maybe all the available tourniquets. That did not happen. There are a lot of them out there. One thing I want to caution is there are counterfeit tourniquets. What? Counterfeit tourniquets? What does that even mean? What that simply means is there are cheaper production tourniquets out there that are not as effective or safe, right? These are some ones that are actually recommended out there on the market that are produced with actually quality. You obviously have the CAT, S-Fit, the SAMS one, and then the Rapid Stop are all good tourniquets. I've used all of these at different facilities and locations. This is applying a tourniquet, some basic steps to applying a tourniquet, things you want to think about. The one thing I wanted to make sure is reemphasizing the timeline. This once again is coming from the TCC's website, is that you think about, I need to get this tourniquet on in about a minute. And then the whole process needs to take about 3 minutes. So this is not a dilly-dally wait around. I need to make the decision fairly fast. Is this going to be tourniqueted versus not? And if I decide to, get it on. Get it on. Call it good. Mark the time and date. It's useful because we do need to know how long has this tourniquet been on there. There's varying studies on whether how long you should leave a tourniquet on. The standard, I think, right now is still less than 2 hours, and 2 to 3 hours is kind of long. I do see some research out there that says up to 6 hours, and I'll tell you, after being in surgery, especially in orthopedic surgery and having witnessed, they pump tourniquets on when they're doing orthopedic surgeries, right? This is a part of the procedure they cut off so it's not a bloody mess. I've seen them been on for quite a while during some significant orthopedic surgeries. Occasionally they'll let them down, then pull them back up, right? So there is some different studies out there on that, but think about if I don't have a time on there as me when you get there, then I don't know how long this is. So it makes it a little bit more of a risky game for me whether I'm going to lose this extremity or not. Some common mistakes. The biggest one, when to use it, right? If you don't know when, you wait too long, then obviously the patient's dead, right? I'm not trying to be crass in there, but if you wait too long, the patient's dead, right? You can put a tourniquet on a dead person, it's not going to help anybody. Not pulling all the slack out of the tourniquet line. This is why it's important to recognize your equipment. I don't actually specifically know which, if I'd have been doing my due diligence, I'll probably come and talk to you guys and figure out which tourniquets exactly you use, maybe to bring some, sorry. But be familiar with the product that your facility uses or the product you're going to use, because you don't need to mess that part up and not get it on initially tight enough, because the windlass or the ratcheting device, which the windlass is the stick that tightens, or the ratcheting device that's going to actually cause that pressure, is only as effective as how tight it was prior to that device being inactivated. Not making it tight enough, using a second tourniquet if needed. This is a great concept, right? If you can't get it to stop bleeding, you're a big old guy like me, you may take 2 tourniquets to get this big, hefty thigh to be like closed off, right? It may take 2 tourniquets, one, start there, and then where are we going to apply that second tourniquet? More proximally. Because why? 2 things. One, I might need to be more pressure, but what if the arteries that are bleeding have actually retracted up further and I just didn't get them with the first one? This is going over hemostatic agents. This is a beautiful change in medicine, because this has made us way more effective at applying basic pressure to non-arterial bleeds. You can still use a non-arterial bleed, but a non-arterial bleed primarily, helping us to get those just draining wounds that are large vessels, right? There's several different products. I'm once again not sure what exactly one you guys use, but it's generally speaking, they're all these kind of foldable gauze. I saw this neat trick while watching the videos. These guys would, I don't know if I would do this before your hands get bloody, but they would stuff the gauze packet up in like a pocket so that it pulls out very accurately. Because I don't know about you guys, anytime I've opened those and they open them, they go, and I'm like, how am I going to pack this in? But they kind of stuff them up in their pocket, and they can kind of pull it out and feed it into the wound really smoothly. It looked pretty cool to me. I thought it was a neat trick. The hemostatic gauze, kind of the history of it, it actually started as like a lot of hemostatic powders and injectables. We've kind of moved away from those because they caused issues. There was also kind of chemical burns that happened. And one of the major issues we noticed with powder as a substance to use for a hemostatic agent was that it blew around in wind. And I don't know about you guys, I don't want blood clotting stuff in my eyes. I like things that are going to cause clots in my eyes. And that's essentially what was happening, is people were dumping this into a wound and it would blow up in the wind and get in their eyes, and they'd get these chemical burns in their eyes. So that's kind of why we've switched over to a gauze format. There are a couple of companies, in fact, there was recently a company coming in showing their product to us in the emergency room that showed that they had basically it starts out as a gauze that can be dissolved into more of a liquid that then can be poured into certain types of wounds. It's applying pressure with gauze. So you want to apply pressure obviously to the source. This is kind of reemphasizing the idea. So 90 seconds is the timeline we're looking for, right? And then once we've got it, I'll emphasize that we want to get this on in that 90-second time period, but the 3 minutes of holding, right? Don't peek. I've done the stop the bleed course multiple times myself during different training processes. Their big thing is don't peek, right? If I apply pressure, I need to keep applying pressure. And I know there's an earlier slide that emphasizes this. If you had to apply pressure to stop the wound, you probably need to think, am I going to need to continue applying pressure of some sort until I get to the emergency room or to definitive care? So we're going to apply this pressure to it. We're going to pack it. I like this 1 to 2 inches, this first section here, 1 to 2 inches above the wound. So this is saying don't just pack to the surface of the skin, pack it above, because that's going to give us something to cram down and push into the surface, into that wound, that's going to help it to get actual good pressure. And then once we've been able to achieve homeostasis or hemostasis, then we can look at applying a pressure dressing to remain pressure. This is like the preventing of the third arm necessity, that we can actually apply this pressure dressing to the site. I kind of want to briefly mention this. These are the difficult areas. Okay, you guys have all got how to pretty much take down an extremity. I'll be willing to bet if I stuck you in this scenario, most of you guys could handle an extremity without much difficulty, whether it's applying a tourniquet or applying pressure. There are some difficult sites. What do I do when it's the neck? What do I do when it's the head? What do I do when it's the axillary, the groin, the chest, the abdomen? These are all way different areas to have to control. I'll tell you the chest and the abdomen. One big thing with the chest, don't be pushing any gauze into someone's chest. You got a hole in someone's chest, don't be pushing gauze in it. You guys have, I believe, chest seals or something like that. That's what you're looking at for there. And similar with the abdomen. Occasionally they even advise putting a chest seal type of wound, a closure wound on the abdomen. You can put more pressure on the abdomen, but it's less likely going to prevent the actual bleed, because there's a whole lot of room to bleed backward than there is that you're going to be able to apply pressure. So the abdomen is, get them to us. They need to be definitive surgery. Apply pressure and get them to us. Chest, don't put things in there. Apply your external dressing to occlude it if necessary. Thinking about the neck, I'm actually going to refer to the once again to the TCC about this, because they actually had some amazing videos on how to tie specific gauze patterns to apply pressure. You will see these, what they call junctional devices, that are demonstrated over here on the left. I don't know if you guys have junctional devices or if you use junctional devices. I've actually never used one in my time in trauma, because mostly as a person in the hospital, we've never been the people that had to use those. We generally send you to surgery if you're this bad. but they are developed by military to apply pressure into those pressure points. There's junctional devices for applying to the femoral arteries. There's junctional devices, as you can see, for applying up in the axillary or up in the neck to apply pressure. The important thing is that you can apply pressure to these. But once again, back to the basic principle, it's pressure, 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 right? We want to apply pressure. If it's a neck, if it's a groin, we still need to fill that void with some gauze and apply pressure. 1 second, my slides jump back. Kind of a thing I wanted to reach back and touch on as I'm getting close. Don't worry, I'm about to let you guys go. See, told you. I'm about to let you guys go to lunch. This is an important concept, and even in the case scenarios I work through, I kind of emphasize this. Don't forget to stress the individual. There's a saying that's classic. I already kind of said it. If it's not your blood, it's not a lot of blood. If it's your blood, it's a lot of blood, right? And I see that all the time, right? If I'm the person that's not bleeding out, I catch myself doing this in the ER all the time myself. I'm pretty used to seeing a large amount of blood. Fact of the matter, I'm pretty used to being soaked in blood to some degree, of the floor being all nasty with it, and it doesn't necessarily register in my brain, but I need to think about, that's not my blood. I'm not the one that's dying. I need to think about the concerns of this patient. And if it's an extremity bleeding, we're not necessarily dealing with the trauma person that's got half their face messed up, they're unconscious, they're tubed or something like that. I need to be able to encourage them, take the time to think about that patient, not just the medical. I'm not saying we're going to have a psychotherapy moment here, but in the moment that once you get things, you've been able to achieve some of this homeostatic, giving those encouraging words is a big thing, because it's going to do something for you. I need that heart rate to drop down. I need that blood pressure to drop down. Those are all actually physiological things that I'm doing. I'm not just helping them psychologically, but I'm also helping them on a physiological thing by giving them some encouraging words to calm down. It's not just about being super mamby-pamby or anything like that. This is actually about applying some actual medical skills to this moment. I'm going to do the same thing my brother did because it's lunchtime. We're going to go through these cases very fast, as you see. I would encourage you can look at them. They are here in their questions. Let me go back, actually. Sorry, I went too far. These are some references, some resources that I'd highly recommend. Some of them you probably recognize, some of them you probably use. They're great resources. I've really appreciated the military background because I know that a lot of our evidence and research and studies and information and updated information on controlling bleeding has come from the military. Because they're just, frankly, they're dealing with this so constantly that they've got a lot of experience in it. So that's why this TCC, there is they provide like a booklet or something that you can get on. They have online available programs and you can watch videos and lectures on it. I really recommend them. Stop the Bleed course that I think they've already offered through this week or the last couple of weeks potentially. And then obviously you guys know your pre-hospital training, life support training as well. Is also a great resource when it comes to understanding this thing. Then, let me go back one more time. Oh, this was just a re-emphasis of the kind of topics we talk about, the importance of managing bleeding. References, questions. I'm going to look at you awkwardly until something, no, I'm not. I'm just saying. You guys, I appreciate you guys so much, really. It's a great career. It's going to be hard. There's going to be burnout. There's going to be all these kind of things. In fact, there's lots of things to be concerned about in your future, but enjoy the process of getting there. Enjoy the process of learning. Like I said, I've been there. This is I started out as a nurse. I went through as a doctor. I actually started as a tech. I leave that one off because it's not as exciting. But I started as a tech and then went to become a nurse and then became a doctor. And I can say that through this education, there's been hard parts of it, but there's a lot of goodness to it. And getting to the end point of this getting out there to actually practice is going to have its rewards. Have things to do in your life that aren't work. I'm not actually, this is where if I was a smart lecturer, there'd be a picture of me doing something cool, but instead I'm just going to say thank you. Thank you guys for all the hard work. Can't wait to see you in clinics in the hospital.
We've got lots of thank yous online as well. If you guys are interested in a PHTLS class, Jeff and I at Bailey, Dane County, there's a group of instructors that do the 2-day PHTLS class about quarterly, right, Jeff? Is that what we're trying to do? Well, that's what we've been doing. We've already had some conversation about doing late March.
Yeah, don't rush to if you're getting PHTLS program. So,
yeah. Probably the weekend.
Yeah,
Thank you.
To help you out.
Yeah. You got to know who to pat on the back.
I don't know a whole lot, Jeff. Have you been in?